Hi, welcome to The Cultural Barrier by Changing Suits. My name's Val.
And my name's Taj.
This week's podcast episode is sponsored by NIHR. And we have a really interesting research study that we're going to be discussing today. Now, as many of our listeners and people that have engaged with Changing Suits knows, we have done quite a lot of work within breast cancer, cervical cancer screening. And this is a really important thing because obviously the NHS is really trying to focus on early screening, especially, well, for the whole society. But when we talk about ethnic diverse communities, that much more and work needs to go into it because there's so many fewer people that are getting that screening done. Now, today, I am going to ask our guests to introduce themselves because many people will know I've got an awful memory as well. So that probably doesn't help. So we've got Lynn and Sadie on today. Could you please introduce yourselves?
So well, thanks so much for having us on this podcast. We really appreciate it. So I'm Lynn Jones. I'm a medical doctor and a consultant radiologist at North Bristol NHS Trust in the Bristol Breast Care Centre. And I'm also the chief investigator for this research study, which is funded jointly by the NIHR and by the Medical Research Council. And it's embedded in the breast screening program, the National Breast Screening Program. It's called FAST MRI Diamond. And I'm particularly excited that we're on this podcast today because the study has recently open to recruitment in both Swindon and in London. So there's a good chance that some of your listeners, might be able to take part. So that's why it's really exciting for us.
Perfect. And we are going to be talking about that study a lot more through this episode. Sadie, could you introduce yourself as well, please?
So I'm the clinical trials manager on the FAST MRI Diamond Study, whilst overseeing the operational side of the running of the study. We speak to women after they've had a FAST MRI scan about their experiences. And I also lead on the engagement and outreach work alongside the recruitment of FAST MRI Diamond.
Perfect. During this episode, we're going to be covering a few topics. So here's the agenda, everybody. What we'll first be doing is talking about why inclusion is so important. Obviously, a lot of our listeners are from the South Asian community and why that's important that we do engage that community. The next part is how we engage that community through research as well. And then we're going to get really technical for everybody. We're going to go into the research study and find out a bit more about the study that Lynn was discussing. So just before we start all of that, in regards to research and inclusion and making sure we've got people from all ethnicities and all communities, why is that an important thing to do in research?
It's really important because what we do in practice in the NHS, what the NHS health policy becomes in any area, is based on evidence. And that's a brilliant thing about the NHS, that it only does things if there's evidence behind it. And the way that you get the evidence is through research. So if you're only involving people in research from one demographic, for example, there used to be lots and lots of research that was done on new drugs, and it was all done in white men, because there was no complication of periods, pregnancy, and various different things that were more difficult to worry about. And then later on, it was discovered that there were problems with that when the drugs were then applied to women. That's a long while ago, but that's the background behind it. So if you're only involving, for example, white people in a particular research study, then the evidence you come up with at the end of it might not be good evidence for other people outside that demographic. So it's really important that in any research study, people take part from every corner of society, every different, ethnicity is just one type of variation that we've got in our society, but we need a broad cross-section of our society taking part in any research study to make sure that the evidence that you get at the end of the research study really represents the whole of Britain, the whole of the people affected by the NHS and who can benefit from the NHS.
Who are the kind of people that are engaging in the studies that you've worked on? Because I'm assuming this study that you're working on at the moment is about to start, or has it already started?
Yeah, we have already started. So we've started first in Bristol, and we're now open also in Swindon and in London and in Cheltenham, and we're just opening in Cornwall as well, in Truro. So we are open, but we're still at the beginning of our recruitment. So we've got a long way to go with our recruitment. So it's just opened. So we haven't got any results. We don't know what's happening. We don't know what the answers are yet. But that's the time that it's important for everybody to engage with it.
And so far, from what you're seeing, are you seeing ethnic diverse communities coming in and getting recruited on the research?
Not enough. Not enough, no.
When we say not enough, I'm going to say how bad is it? But I know that sounds really simple, but what kind of, how bad is it?
Numbers, yeah.
I might hand over to Sadie for that, because I know she's got the more up-to-date figures. And
are we going to cry, Sadie? That's what I'm trying to get to.
So what we've done, because like Lynn said, we've only opened in certain sites. So what we don't want to be doing is using national ethnicity to extrapolate to Bristol, for instance. But we are still seeing, even if we use Bristol, which is a very diverse community, and we've had much greater numbers of women generally through, because it was an earlier starting study, much lower numbers of the diversity we would expect if we're looking at Bristol's communities. We've done a lot of work where we've gone out to communities to talk to them about the study. We've done that before we ran the study, before it opened, to talk to them about what we could do to include as a diverse group of women as possible, and we've taken that on board. And we've also, especially now that we're still not seeing that representation pulled through, we're going back to those communities and talking more about what we can do. We monitor at different levels as well, the ethnicity that comes through, because unfortunately breast screening itself is underrepresented, and then research as well. So there's two tiers where unfortunately we are, it seems, losing women that aren't taking part in the FAST MRI Diamond Study. So we would very much like to increase that diversity there. And any feedback you or your listeners have about what we can do about that, we'd very much take on board. And any barriers and experiences that anyone would like to share, we're always open to talking about.
We're really keen on doing this is because, like I said earlier, one of the areas that we're looking at is getting people from women from the South Asian community to go for that early screening. In fact, we are working with Kingswood Medical Group, and one of our changing suit staff is sitting in practice to have those conversations with patients who have not attended their appointments, for example. And it's really interesting, the conversations that we're having with them and the barriers, both cultural, systemic, as well as, the fear. I mean, I don't think there's, any other way of saying that. And that crosses all cultures, doesn't it? That fear aspect of it. But what other barriers are you seeing in research that is preventing people from going to get that screening? Because then it then prevents them getting recruited onto your study there.
I think the first thing to say is that breast cancer, that there are some really good treatments for it now. So whereas if you go back to my parents' generation, which is going back a long way, then there was a lot of fear amongst women then, because the understanding was that if you got breast cancer, it was a death sentence. And things have changed so much in my lifetime, and it really isn't now. The vast majority of women who get a breast cancer diagnosis will survive it. and I don't just mean survive it in the short term, I mean they survive it in the long term and go on to die of something else a lot later on.
Yeah.
So, and that's because the treatments we have now are really effective. But the earlier you can find the breast cancer, the better the chance the treatments have of being effective. So that's why there's this drive to get breast cancer found as early as possible. And it's a completely understandable reaction if you find a lump or something, you get frightened about it and you think you keep putting it off and decide not to tell anyone. But that's exactly the wrong thing to do. The important thing is to tell your family and go and see the doctor if you do find any signs in the breast, because the earlier you can find a breast cancer, the more chance that you have of a really good outcome at the end. So that's the first thing to say, and that's not true of all cancers, but it is true of breast cancer. So that's why the breast screening program is there. And the breast screening program, we know, saves over 1,000 lives every year from breast cancer.
Diamond Study, they have to have taken part in their first mammogram, and it's only for women 50 to 52. So it's a very small cohort of women, and therefore there are barriers to attending that appointment and therefore being eligible for the study.
So it's really, really important to go to your breast screening when you're invited. But I know that it can be difficult for many reasons for people to go. There's pressure of people are very busy nowadays. I've really enjoyed listening to some of your other podcasts and hearing how you're all involved in working and looking after the home with many responsibilities, and a lot of women are in that situation, and women tend to prioritize their health less than other things in the family, and so that can be a barrier. But for many reasons, the big thing about the NHS breast screening program is that it's an all-female staff. And I think that's an important thing for many communities, and many communities might not realise that. But the people, the clinical people that you see within breast screening, the mammographers doing the mammograms, they're all female within the screening side of things. So that makes a difference to some people, and that can be a barrier if people don't realise that.
The other thing that I found interesting when we started off the project was the fact that, well, actually, the South Asian community actually has a lower incidence of breast cancer, but they're not going to get their screening, which means when it is actually found out they've got breast cancer, it's at later stages. So there's more complications. And that I found striking in itself to think that, whereas obviously that's not the case with other cancers. Regards to the study now that you're doing, with the fact that some people do not go to get their breast cancer screening done, what is the impact then on the research project that you've got at hand going on now? And we will explain a bit more about what that research project is, because it's actually really exciting. I feel like I'm doing that EastEnders, dun, 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 what is the research project? So Sadie, do you have any figures as to how many people are getting involved from the community there?
Yeah, so we've recruited so far about 200 women, and of those women, only 6 have been non-white. Therefore, there's 2 angles to it, really. There's the clinical implications, like Lynn mentioned earlier, and the findings that we find clinically. But also, we then are unable to have conversations with more women about, and this goes back to the work I'm doing, speaking to women that have had the FAST MRI about what we can do to make it better, because we have almost this clinical research bubble, and we use acronyms and words that are used so frequently at work that we don't realise that they're not used outside of our bubble. So it's so important to step outside that bubble and speak to women from diverse communities to find out where we might not be getting it quite right, if there's something whether it's actually something part of the scan, part of breast screening, or even the words that we use in our information leaflets, where we could be making that better. Because if we're only speaking to one demographic of women, for instance, white women who have English as their first language, they might not have the same questions, maybe as other people do, about translators, about even caring for the family, whether there's any support there. And especially in our public and patient outreach groups, we make sure that we fund costs associated with caring responsibilities, because in some societies and some communities there might be more of a burden on looking after the family there. So if we don't ensure that any woman that might be interested, and we're not forcing anyone to take part in research, we don't want to come from that angle, but anyone that is interested or may like to take part in this study or other studies, we want to make sure that we have given them everything we can do to support them to attend. So we can, there are benefits published of taking part in research, so there should be some slight direct benefits in some cases, but also benefits to their community of the findings that we get from the study as well.
Okay, we're going to go into the study now. I've heard a bit about it, so I'm actually really excited about learning a bit more about it. Lynn, could you give us the overall, what is the study about and what you're looking to do?
Okay, so as I said before, the NHS breast screening program is doing really well and it is saving lives, but it was set up in the late 80s, and so it's the technology. We've got a lot more technology now than we had then, and things have improved along with that timing, but we want to see whether we can make it even better, because there's this much newer technique called FAST MRI. MRI stands for magnetic resonance imaging. It's a scan where instead of with a mammogram that uses X-rays, it uses a strong magnetic field. You have to lie on your tummy in a tunnel, and it makes lots of noise. But at the end of it, you get really, really detailed pictures of the breast, and the most aggressive cancers show up very, very clearly, even when they are tiny, smaller than a centimetre. And it's difficult to see them when they're that small on a mammogram. So the current breast screening program is doing very well, and we encourage everybody to take part in it. But what we're trying to find out is whether we could improve it even more by introducing this new technique called FAST MRI.
Lynn, can I on that point? So
Yes.
the current screening program, we're all encouraging people to do it. It's there, it's free. You get sent appointments. If you don't get an appointment, you can phone and get an appointment booked in. There is a local clinic wherever anyone is in the UK to get that done. But why would we move from that one? What are you finding are the issues with that screening, and why is this research being done?
So the whole idea behind the screening program is to find breast cancers earlier, before we can feel or see them for ourselves. And the NHS breast screening program does that with mammograms already. But FAST MRI, we think, will be able to find them even earlier. And so we think that might improve the percentage of people who survive their breast cancer even more.
What age will those women be called to have this MRI FAST scan?
So we're looking at the youngest age within the current screening program. So women are first called when they reach 50, but because it's a 3-year cycle, you could be any age from 49 and 8 months, but virtually 50 until 52. So at any of those times, depending on, because it rotates around each area, you could get the call for your first ever screening mammogram. So we're just looking at women called for their first screening mammogram. So in order to take part in Diamond, you have to actually turn up for your mammogram and have your mammogram.
Why the first one in particular? Why is it the first one that you're...
Well, we thought when we were setting up this study that the most important group of women to think about, what we're trying to do is work out which group of women can benefit most from a fast MRI, because we're not going to be able to offer it to everyone.
Realistically, yes.
So realistically. So what we were thinking was maybe it's the youngest.
Why can't you offer it to everybody? Is it a cost association to it?
Yes.
And, okay, no, that's fine. And if the research was found to be positive and you could catch cancers earlier than the current screening program, is there potential that actually it could be for anyone later on?
So what we're doing is, parallel to seeing whether it can pick up these cancers smaller, we are also looking at the feasibility. So we're seeing of how many, we see if we invite this number of women to come, we're taking a record of how many people turn up for their mammograms. And of those people who turn up for their mammograms, how many are taking up the opportunity to contact us and say, yes, they'd like to be part of it. Important that we try and work out whether it's practical to offer many more women a fast MRI. So we're doing, we're looking into that. So we're seeing how many MRI slots we can get. And that is a limiting factor. But so far at the sites that we've opened, we've found that they have been able to provide the number of screening slots on the MR machine that we've asked for. With it, I mean, they've done really well in doing that. So,
how early does the current screening system pick up the cancers? How big do they need to be? I don't know if that's how you measure it, or how. I'm not sure. How quickly does it? How early does it pick up a cancer?
Well, it can pick them up very early, but it depends on so many different things, because not all breast cancers are the same. There's so much, in the same way as people are very different from each other, breast cancers are very different from each other as well. There's tremendous heterogeneity of breast cancer.
We need to be inclusive for cancer as well.
We need to try to be. We need to try to be more inclusive for cancer. It's really true. It's really true.
Do they pick up the size? Sorry, I know you've answered it, but I just in my own head, is it the size of the cancer that it's like actually now you do have cancer? Or what is it?
So yes. So before you can feel and again, whether you can feel a cancer in your breasts yourself will depend not only on the cancer, it also depends on your breasts and how near the cancer is to the surface. So that would vary, but you'd be unlikely to be able to pick something up less than 12 millimeters across unless it was really near to the surface.
With the current screening?
No, ourselves, when we examine ourselves.
Right.
And so, screening? And screening, and you may not feel something that's 2 or 3 centimeters in size if it's right at the back of your breast, in the middle of your breast, and you have big breasts. Mm. So that's what I mean. You can't really say size. And then currently with screening, we can pick up sub-centimeter cancers with screening. But again, it depends on the sort of cancer, because some cancers show up as little dots of calcification, which show up quite well on a mammogram. And so you might find a very tiny cancer in some ways. Also, some cancers distort the breast. In fact, that's why cancer is called cancer, because it's like a crab. Cancers, like the zodiac sign Cancer the crab. And it's because it pulls in the tissue around it. But not all types of cancer do that. Now, if a cancer is pulling in the tissue around it, it shows up very well on the mammogram, even when it's tiny. But some cancers don't. They just replace the tissue around them without changing it. and they don't show up on a mammogram until they're a bit bigger, maybe a couple of centimeters.
So if someone has quite large, I don't know if you could call it large breasts, and the cancer is quite far back, firstly, someone would find it very hard feeling that.
Yes.
Because it might not be at the surface, but a mammogram can pick that up
Yes.
to a certain extent. Therefore, the MRI, I'm assuming, goes that much more deeper.
The mammogram will see right to the back of the breast.
Right.
So it will show you the whole breast.
Okay.
And it works very well. The thing about the MRI is because what we do, part of the FAST MRI is to have an injection of a dye, and the dye gets circulated around your bloodstream. And so it goes to anything that's got a high blood supply. So you show up, you can see on the FAST MRI, you see the heart, you see the blood vessels, and you see the cancers, even if they're tiny, because they've got this high blood supply.
Okay, that makes sense.
So even if they're, smaller than your little fingernail, they show up, they light up like a beacon on the FAST MRI. Whereas on the mammogram, if you don't have an injection of dye at the time of the mammogram, and mammograms traditionally don't have an injection of dye, you don't see them unless they're doing something else, like pulling the tissue in or making these little dots of calcification. You don't see them till they're a little bit bigger.
How are people being invited in? So they're being sent the first letter for screening, and is another letter sent with it for this study, or how are people knowing about this research that is taking place, and how do they get involved?
So in order to take part in the research, they have to come for their screening. So
they literally have to physically be there and then it's discussed. Oh, right, okay. Yeah.
So when they turn up for their mammogram, whether it's in a van, because that comes around locally, or to the supermarket car park or wherever, or whether they go to the screening centre, when they go in, the radiographer or the receptionist will give them a leaflet about the screening study and say, oh, I think it's your first mammogram. If it is your first mammogram, you've got the chance to enter this study if you'd like to. And then you can either do a QR code with your phone to get the link to be able to consent to take part, or you can actually fill it in there. They'll lend you a pen to fill in a paper form that you then fold up and post into a box before you leave the screening. And then,
so are the staff members, given information? Obviously, they're told about what this study is, and they'll discuss it with the patient. Because if you're handed a letter, you're like, okay, that's brilliant. Okay, let's go for the mammogram. So are the staff members told more about the research and stuff like that, so they can discuss it with the patient?
So unfortunately, this is a cost thing as well. So because the screening, I think you get like 3 minutes or maybe 5 minutes with a radiographer when you have your mammogram. It's a real conveyor belt thing, in and out. It's the only way they can make it cost effective. So one of the things when we were setting up the study was they said, we're not going to be able to discuss it with people. And so we said, that's fine. So you give them the piece of paper. It's got the QR code. If you follow the QR code, there's a little video that explains it. And also it gives you the contact address of your local, and I think also the central team, so that you can email or is it text as well? I'm going to have to ask Sadie exactly the details of what's on that piece of paper, but there's a way of contacting, and then you can ask questions. Sorry, Sadie.
Yeah, so you can email or phone. It's up to sites what information they give on their local. Some might not have the infrastructure for a specific dedicated phone number, but sites will have at least an email address, or they can contact us by phone centrally. But also one thing to point out is that whilst we are asking or inviting women to take part on the day, they will be given the participant information sheet to take home. And if at any point they do want to withdraw, they can withdraw at any point. There's a 5 calendar day window before we do anything with that person's data. So we have to send off the mammogram images outside of the central team and the site. So we will not send out anything, and it's clear in the participant information that we will not touch those mammograms and send them for 5 days. So women have got at least 5 days to consider whether to take part and allow those mammograms to be sent off. If at any point they do not want to take part, if it's before those 5 or within those 5 days, then they just don't get sent. If women would like to withdraw after they've been sent, we can stop collecting data and not process any more information. So there is a way to withdraw if they do change their mind at any point as well, because we do appreciate it is a lot to think about on the day, which is where we were in, like Lynn said, in that difficult position about approaching women for the first time at their appointment, which wouldn't have been our first choice. And we did go through lots of other ways, but unfortunately it is the way that we've had to come to. But with that window, women are able to withdraw before anything happens to their data.
So interesting. I mean, you can see the barriers that are already put up for yourselves as researchers in this scenario. I mean, it sounds like an absolutely fantastic project, research that going forward could make such a difference to so many lives, and in that early diagnosis and screening aspect. But then even from the work that we're doing, we're seeing, from the cultural aspects is actually getting people to the appointments. You've then got a challenge of actually getting that message across, because I was just at the breast cancer screening for my mum, and it is a case of, you can see the conveyor belt aspect. I mean, we're fortunate to have the NHS and these free screenings. I mean, if you're not taking advantage of it, it's just mind blowing. For whatever reason it is, that's very judgmental. I've just said that. How judgmental is that? But the other part is, actually, is there that time for someone to talk about that research? Because if you don't have the information that you've just discussed with us, I probably wouldn't go and give that a call or send the email to get involved in that research either, because it's very hard to convey that message at a certain to a certain extent. In regards to the actual process of, if you do the screening, you've got the paper and you're actually interested in getting involved in this research, because it sounds fantastic, just the technology that is out there. What is the practical step? So you've said, yes, you've waited those 5 days. What's next for that patient?
Then once the 5 days is up, assuming that no one's asked for their data to be withdrawn, we look for 2 things. So first off, to take part in the study, you need to be average breast density, which I think Lynn will cover a bit later, which about 40% of the population has this average breast density. And also you need to have been given, it's called a routine recall letter. So it's a letter saying that they haven't found anything abnormal on your scan. They don't want to check anything or invite you back. They'll just invite you at the next screening call in about 3 years. So the site team will look for those 2 things. To be able to get that breast density, they need to send it off to a hospital in Surrey. So that then gets sent through an AI algorithm tool to assess that breast density, and that then gets fed back to the participant. If you have this B density, this average breast density, and that routine recall letter, then our team will contact you and they'll give you another bit of information. So what we've done in this study, because there is quite a lot of processes to go through, and not everyone, unfortunately, that consents at the mammogram appointment can and are eligible to take part in a FAST MRI scan. So we've broken it down in 2 parts. So if they do meet those 2 criteria of the density and the receiving that routine recall letter, the site team will contact the women with the stage 2 information. So this is information that's specific to the FAST MRI scan. That will usually be emailed out to the participant, so they've got time to read through. If they've read through all that information, and they get a copy of the consent form as well to look at what they need to consent to, then they can contact the site back, or the site might contact them and ask them if they want to book in a consenting appointment. If that participant is happy to take part after reading all the literature, and maybe the videos that Lynn mentioned before that can be looked at any point during the study, then the consenting call will be booked with one of the research nurses. So this is an appointment on the phone, usually on the phone. It can be up to an hour long, so it goes through lots of questions. Most of the time it is going through consenting, so going through that information that was sent and the consent form, making sure that the participant fully understands what the study is, making sure that they're clinically able to have the FAST MRI scan, so making sure that they've got nothing that clinically means that they won't be able to have. So there's there's types of implants, and Lynn, you'll probably be able to chip in about the reasons, like some people might not be able to have a FAST MRI scan. And then we'll do things like take demographics. So that helps us make sure that the study itself is representative, and we can look at that at the end of the study and monitor it during the study of whether we're being inclusive, and at time points, is there anything we can do because we're not capturing a certain demographic of people.
Of course, with research, I think number one, even from anyone's point of view, would always be that safety aspect. And that's quite clear. There's so many loopholes that you have to go through to get to this point, which is, it's just mind blowing. I mean, you can see why research takes so long. It's amazing, and it must be quite frustrating as researchers to have to go through all. And it is correct, obviously, with everything that's happened in the past, it has to happen. But the great thing to hear is those safety protocols are in place. They are in place to protect communities, protect participants in research. It just takes that much longer, which is the right thing to do. So once the patient has been is eligible, and you're like, yes, we've got a participant, she's got the right breast density, she's gone to her screening appointment, perfect, we're in the right place here, and she's consented all the way. On the day, what are the procedures that then take place for that patient?
So she'll receive her appointment letter. They're called in just like with any other MRI appointment. They get called through by one of the support workers, who will give the woman a gown to change into, and then they'll have a locker to put their things into and get given a key to make sure everything is kept safe. When they're ready, they go through the screening form again. So the clinical side that we go through on the phone, the radiographer or the support worker will go through that again. So we go through it just to make sure the woman isn't being invited for a scan that when she turns up she isn't eligible for. Assuming that the woman is eligible, she then gets the cannula placed in her arm. So this is done by very, very experienced members of the team that do it day in, day out. So it's usually very quick and relatively painless. And then they go through to the MRI scanner. I'll pass on to Lynn now, who would give a bit more detail about once they're in the MRI scanner from the clinical side.
Thanks so much, Sadie. Yes, so you go into the room and the radiographer comes in with you, and then you have to lie on your tummy on a table. So there's a table that moves in and out of the scanner, which is like a bit of a tunnel. So the tables come out when you go into the room. The radiographer helps you to lie on your tummy on the table with your head furthest away from the scanner. And underneath you, where your breasts are, there are like two cups. And the radiographer will help you to place it's female radiographer, and they help you to position your breasts into the cups. And it's really important to tell them if it's comfortable, if it's not comfortable, because once you're in there, they want you to stay very, very still. And that's a really important thing. So the scan itself takes less than 5 minutes. But from when the scan starts, it's really important not to jiggle. Even a tiny, tiny bit really matters. So it's important if they're positioning you and you think, oh, that's a bit sore, I'll wait till they've gone and then I'll move. It's important that you say, oh, that's a bit sore. Can you change this or that, or put a bit of extra padding here or something? Get really comfortable. When you're happy, then what they do is they press a button and the table slides back into the scanner. And really, you can sort of just imagine that you're lying on a beach or something, because it's you're lying on your tummy, maybe with your arms above
You're selling it
your head.
nicely.
Anyway, the problem with imagining that you're lying on a beach is that it then starts to make an awful lot of loud noises.
Yeah.
So they will have given you some headphones to cover your ears to protect it, but it does make some very strange loud noises during it. And they'll talk to you over the intercom, so you'll be able to hear them. But apart from the loud noises, it's not unpleasant. They'll warn you when the dye is being injected through the cannula into your vein. But most people don't feel anything at all when that happens. Some people feel either cold or warm going up their arm, but that's all. And then, as I say, it takes under 5 minutes to acquire the scan, and then they come back into the room, press the button again, and it comes out, and they help you up off the table, take you outside, and then you get changed. And then just before you leave, they'll take the cannula out for you and make sure it's not bleeding.
Lynn, how long does it take to get the results? And does the patient get the results themselves, or does it go through a GP? Because one thing that we've understood when we are talking about any research is making sure that the people who are involved do get the information back as well. How long does it take, and does the patient get that data?
Okay, so the way that the FAST MRI provides a whole set of images, which then need to be looked at by the experts within the breast screening program. And the way that it's done is it needs to be read by two experts. So these are the same medical professionals who normally read and interpret the mammograms, and they've had additional training so that they're all able and credentialed to be able to read the FAST MRI as well. So it will take at least a couple of weeks to get the results back, because it has to go to two readers, and if they disagreed, it goes to a third and a fourth reader, and it can be quite complicated how many people it goes to. So, but that process all happens within the research trial. And if there's nothing abnormal seen on the FAST MRI, then the participant will get a letter from their local delivery team to say that it's all fine, there's nothing abnormal at all on it. And that's the end of their participation in the Diamond trial. But what we will be doing at the end of the Diamond trial is we will be sending the results to everybody who has taken part. So that will be a lot later on, probably a year and a half or 2 years later, they'll be sent the results of what the whole trial showed.
Okay.
So there's two other categories that, so the vast majority of people, there'll be nothing the matter with the FAST MRI at all. There's two other categories that the results might be. So one is if there's nothing that looks at all worrying on the FAST MRI, but people weren't completely 100% sure, though they were 99% sure. And under those circumstances, what we do is we send a letter just to say, there's nothing to worry about at the moment, but we would like to scan you again in 1 year's time. So that will arrive by letter.
And is that an MRI scan or
yes.
a mammogram? Okay.
You don't have another mammogram in the trial, but you would have a repeat FAST MRI in 1 year's time. So about a month before, you'd get a phone call. I think that's how we plan to do it. Or you'd get a message to say what time would be a good time for us to call you. And then you'd have another call with the research nurse locally. That's going to be maybe, I don't know, 1 in 10 or to 1 in 20 of participants would get that letter instead. And then the third category is if there's something on the FAST MRI that we're not expecting that we need to look at in a bit more detail. And if that's the case, then you don't get a letter. Instead, you get a phone call.
Okay.
Because we've been told by all the work that Sadie's done with talking to participants of other trials of the screening in general, what we understand is that if people are not expecting to be told that they have to do something more, and they would prefer to have a telephone call with someone who can answer their questions, because they're bound to have lots of questions about it. And so they want a call with someone who can answer those questions. So we've designed this trial so that if you fall into that category, then you get a phone call from the research nurse who's able to say, well, this is what we want to do next, and this is what it would entail. And then we arrange for those people to come back, actually physically come back to the hospital to a screening program assessment clinic, where they see a professional who, usually a radiologist, but it could be a breast clinician or an advanced practitioner radiographer who's trained to do ultrasound, who's also trained with fast MRI, mammograms, all the different technology involved in breast care. And they will look at the breast in more detail to find out what it was that was seen on the fast MRI, and they will take a biopsy, a needle biopsy, to find out what it is. We're not expecting all of those people that we call back to have cancer. We're thinking maybe if we call 5 or 6 people back, maybe one of them might have cancer. So even if you do get called back, the chances are you don't have cancer, but there is a chance that you might have, and we'd then be looking to diagnose that as quickly as possible and get you into the normal breast cancer pathway for treatment as soon as possible as well.
What's really interesting, and as we come to the end of this podcast, it's really interesting to hear, like I said earlier, how much safety, how many protocols are followed throughout the whole of the procedure. You know, we've had people talking in other podcasts about how much those participants are looked after. And especially from what you've said, it is a case of we've got a fantastic screening program. This then goes above that screening program to really try and not only get that information, but if there is anything, get that faster than perhaps what the mammogram program at the moment could get. So there's so many advantages of getting involved with this project. There's so many loopholes that you have to go through as researchers, making sure that participants are safe. But also it is there to help future generations, future communities, future systems within and screening systems within the NHS. So hopefully this can be rolled out on, if there is hopefully positive results from the trial, that this can be rolled out more widely. But of course that could take time. But it's so important that we do participate in research like this, not only to help those researchers that are doing it, to help ourselves, but also help future communities. If someone does want to get involved, what are the steps that they need to be taking right now? And to be fair, I think you've explained it so well. I'm going to do it. And if I make a mistake, you tell me if I've made a mistake. Get your mammogram done. If you are called, you will be given information at those sites that Sadie and Lynn have discussed. Please do go away, read that leaflet that's given, get in touch if there is any other information that you are after, and then pick up the phone to get in touch with the research team and find out if you are eligible for this research project. And then after that, you will take over and give all of the directions that someone would need. Am I correct in all of those procedures? Yeah, I've got a yes. Okay, perfect. What we will be doing with this episode is giving further information in regards to the trial, so that anyone that is interested will have the link to the website and further information of what we have discussed today.
I just wanted to say thank you so much for giving us this visibility, because it's so important to get the message across, as you say, because people are turning up to their screening appointment and they haven't heard about it before, and it's a bit overwhelming to come for your screening and be given something else that I'm sure a lot of people would just put it in the bin. So if they've heard about it first on your wonderful podcast, it's much less likely that that's what they're going to do, because they'll be looking out for it. So I'm so grateful. Thank you so much.
Thank you so much for coming on and explaining the trial to us, and I'm really excited to find out the result of it as well in a year and a half or whenever that happens. It sounds like it takes its time, but the point is, get involved. If you can get involved, please do. That's goodbye from me.
And goodbye from me.
Follow us on Instagram and Facebook for changing _suits, so you never miss an episode.